Right, so I'm presenting on approaches to the shoulder and humerus. So in terms of the approaches to the humerus and the shoulder, there are many different approaches. I had a bit of a chat to Theepan and a few of the consultants and just tried to use some of the approaches that are potentially less frequently used in our day-to-day trauma load. But we'd be certainly very interested in any input from the shoulder surgeons in the unit at the end of the discussion, as my knowledge is largely academic in these sorts of approaches without as much clinical experience. So the approaches I'll be talking about will be the posterior approach to the shoulder joint, the anterolateral approach to the AC joint and subacromial space, the posterior approach to the midshaft humerus, and the anterolateral approach to the distal humerus. So starting with the posterior approach to the shoulder joint itself, the indications for this approach are repairs in the setting of posterior dislocation or subluxation, glenoid osteotomy, biopsy, removal of posterior recess loose bodies, washout and drainage of the shoulder joint, scapular neck fracture fixation, and also posterior fracture dislocations of the shoulder. So the positioning, as you can see, is the lateral position usually. It's important to drape to allow for movement of the arm independently. The landmarks and incision in the posterior approach to the shoulder involve the acromion and the spine of the scapula as the landmarks, as you can see in the top right. And the incision is a linear incision along the length of the scapular spine to the posterior corner of the acromion. The internervous plane in the posterior approach is between the teres minor supplied by the axillary nerve and the infraspinatus supplied by the suprascapular nerve. As you can see, there's that interval in the picture. So the dissection with all dissections is divided into superficial and deep. The superficial dissection for the posterior approach involves detachment of the origin of the deltoid on the scapular spine and finding the plane between the deltoid and the infraspinatus. It's easier to locate the lateral at the lateral end of the incision. The deep dissection involves blunt dissection with a finger between the infraspinatus, which is retracted superiorly, and the teres minor, which is retracted inferiorly. And at this stage, it should expose the posterior inferior corner of the shoulder joint capsule, which you can see there. And then the deep incision of the capsule is longitudinal, close to the edge of the scapula. So the dangers in the posterior approach to the shoulder joint to be aware of are the axillary nerve, which runs through the quadrangular space beneath teres minor. And hence why that's important to ensure that the infraspinatus and teres minor interval are maintained. The suprascapular nerve, which passes around the base of the spine of the scapula, running from the supraspinous fossa to the infraspinous fossa, and this can be injured with any heavy medial retraction of infraspinatus. It can cause a neuropraxia as the nerve is stretched around the lateral edge of the scapular spine. The vessel at risk here is the posterior circumflex humeral vessels, which run in with the axillary nerve in the quadrangular space beneath the inferior border of teres minor. So enlarging and extending this approach, in terms of enlarging the approach for improved deep exposure, infraspinatus can be detached 1 centimetre from its insertion at the GT of the humerus and retracted medially, which you can see in that diagram. Caution of the suprascapular nerve in this process. This approach, the posterior approach to the shoulder joint, can't be extended particularly usefully. So moving on to the anterolateral approach to the AC joint and the subacromial space. The indications for this, the anterior decompression of the shoulder, rotator cuff repair, the long head of biceps repair, and AC joint osteophyte excision. So this approach, the positioning is usually supine, From reading, a sandbag under the medial border of the scapula can assist with your access, and usually with a beach chair, so some level of head up, which in Hoppenfeld was 45 degrees. The landmarks and incision for this are the coracoid process and the acromion, as you can see here. And the incision is a transverse type incision from the lateral corner of the acromion there to the lateral aspect of the coracoid. That's a diagram there showing the transverse incision from the lateral aspect of the acromion to the lateral aspect of the coracoid. So the internervous plane, there's no true internervous plane, as deltoid is detached proximal to the axillary nerve, which I'll show in a diagram shortly. The dissection, again, divided into superficial and deep. The superficial dissection of the deep fascia and incising this in line with the skin. There's two different or slightly different approaches to this. If the approach is for a subacromial decompression, so no cuff repairs required, then you're detaching the deltoid fibres attaching to the AC joint and continuing with sharp dissection laterally to expose a centimetre of the anterior acromion. It's important to know that you'll encounter the acromial branch of the coracoacromial artery, which needs to be controlled or ligated. If the approach is being used for a rotator cuff repair, you actually split the deltoid fibres, split the deltoid in line with its fibres, starting at the AC joint, and then you extend this 5 centimetres inferiorly, and then place a stay suture at that inferior apex to prevent any further tearing of the deltoid. You then detach the deltoid arising at the AC joint and continue your lateral dissection as previously. So that's showing that initial dissection, and then the deep dissection involves detaching the ligament from the acromion by sharp dissection or with a bony block for repair back, and then this should expose the underlying supraspinatus tendon with its overlying bursa. The dangers in this approach are the axillary nerve, which runs transversely, as you can see in the image there, on the deep surface of the deltoid, and it's approximately 7 centimetres below the tip of the acromion. And that's why we use that stay suture to prevent further inferior damage to the deltoid. And as I mentioned, the acromial branch of the coracoacromial artery, which runs immediately under deltoid and is usually divided and ligated during the superficial dissection. There's further enlargement, the detachment of the deltoid is not recommended because it's very difficult to then reattach the deltoid, and no extension is really available due to no internervous plane being available. And in this diagram you can see the example of that stay suture at the inferior aspect of deltoid, stopping inferior migration towards the axillary nerve. Moving on to posterior approach to the midshaft humerus, which I did one of earlier in the year with Mr. Taylor. The indications for this are fracture reduction, fixation, treatment of osteomyelitis, biopsy, treatment of non-union in the setting of either operative or non-operatively managed midshaft humeral fractures, exploration of radial nerve, insertion of humeral nails with an open reduction type technique. So you have the option of both lateral or prone positioning for this operation, with normally either an arm table with the elbow at 90 degrees or in the lateral position with the arm over a gutter or an arm bolster. So the landmarks are the acromion proximally and the olecranon tip or the olecranon fossa distally, and it's recommended you undertake a longitudinal posterior midline incision that commences approximately 8 centimetres below the acromion to just above the olecranon fossa, and obviously that's depending slightly on where your fracture is. There's no true internervous plane, rather it requires separation of the heads of triceps. So the dissection, the superficial dissection, involves incising the deep fascia of the arm in a longitudinal fashion down the midline, and then identifying the gap between the lateral and long heads of triceps. Proximally, that can be achieved with blunt dissection between the long head medially and the lateral head laterally, but distally often you require sharp incision through the muscle there, as you can see in the diagram. The deep dissection with the medial head on view, the radial nerve runs proximally in the spiral groove. It's important to then incise the medial head in the midline to the periosteum, and they've noted that it's important in the dissection that you need to remain in the epiperiosteal layer, as the ulnar nerve pierces the medial intermuscular septum as it passes from anterior to posterior in the distal third of the arm. So the dangers, as I've sort of mentioned already, that are there are particularly the radial nerve, but that is one of the great benefits of this approach, is visualising the radial nerve and ensuring that there's been no injury to it during the fracture or through the operation. So it should be identified at the spiral groove. It's important that you don't continue proximal dissection to bone before you've identified the radial nerve and often looped it so you can control it. The ulnar nerve, as we said before, is deep to the medial head of triceps in the distal third of the arm, and it can be damaged as you're elevating muscle off the humerus, and they talk about using this epiperiosteal layer to try to prevent that. The profunda brachii is the vascular structure that's important, and that lies with the radial nerve in the spiral groove. So in terms of enlarging or extending this approach, proximally bone actually can't be adequately accessed above the spiral groove from a posterior approach, and that requires an anterior incision, and that's why it's important to decide on your approach depending on your x-ray and your location of your fracture. Distally, interestingly, this can be extended over the olecranon and provide access for an olecranon osteotomy to look at the articular surface and address any concerns with the elbow joint. And finally, the anterolateral approach to the distal humerus, particularly used for Holstein-Lewis type fractures, so the distal sort of fourth distal quarter humerus fractures. So open reduction, internal fixation, again biopsy of distal lesions, and this is useful for exploration of the radial nerve in the distal aspect of the arm, which can also be associated with your Holstein-Lewis type fractures. So positioning for the anterolateral approach to the distal humerus is usually supine with an arm table, and the arm is often abducted at around about 60 degrees, but really wherever the surgeon has best access. The landmarks in this approach are the biceps brachii, the muscle belly itself, and then the flexion crease distally at the elbow. It's normally a curved longitudinal incision based on the lateral border of the biceps, and it's approximately 10 centimeters proximal to the elbow crease following that muscle contour, as you can see in the diagram. Again, there's a bit of a running theme, but there's no true internervous plane. Rather, the plane is between brachialis and brachioradialis, with brachialis being the radial nerve and musculocutaneous, and brachioradialis and the radial nerve. So the dissection for the anterolateral approach to the distal humerus involves incising the deep fascia longitudinally and identifying the lateral border of biceps, as I mentioned. Then retracting the biceps medially and identifying the interval between brachioradialis and brachialis and dividing the fascia that's overlying these. And that's where you develop your intermuscular plane. You should then be able to identify the radial nerve between the two at the level of the elbow joint, and the recurring theme that came up when looking into this approach was that the radial nerve's easiest to identify at the level of the elbow joint, so that's the best place to go looking, but it's important to then trace the nerve proximally to find its point at which it pierces the intermuscular septum as well. And that's just showing there the radial nerve laterally. Moving on then to the deep dissection, and incising over the lateral border of brachialis longitudinally onto bone, and then incising the periosteum of the anterolateral humerus and retracting brachialis, as you can see there, medially by raising the anterior aspect off the bone. Again, they've said it's important there using subperiosteal dissection for preservation of the surrounding structures. So the dangers of this approach include the radial nerve, as we said, which is important to trace from the elbow level proximally, and the lateral antebrachial cutaneous nerve, which can be injured with the retractors when you're retracting your biceps medially. Interestingly, you can extend this approach distally and proximally, which can be quite useful for access to the elbow. So proximally, by developing a plane between brachialis medially and the lateral head of triceps posterolaterally. You do have to be careful proximally with your dissection of the radial nerve if you're drifting posterolaterally. Distally, you can extend this into an anterior approach over the elbow, so continuing distally and developing a plane between brachioradialis and pronator, brachioradialis with the radial nerve and pronator and the median nerve. But it's important to watch out for the lateral cutaneous nerve of the forearm running along the lateral aspect of biceps when you do extend this incision. Thanks.